Hello doctors, now let's see what is resin bonded restorations. For that, what is resin bonded restoration? Any restoration which is bonded with help of a resin, that is composite resin. That means a preventive prosthodontic procedures have to be emphasis onto the fact that we are not preparing the tooth much. So conservation of the tooth structure here is another important aspect. And so for that we have to find out what are the other ways of restoring a teeth which is missing in a particular arch. Coming to the definition of this, a prosthesis that is luted to the tooth structure, primarily enamel which has been etched to provide mechanical retention for the resin cement. Classification of resin bonded prostheses are like Rochette bridge, we have Maryland bridge, we have cast, mesh, fixed partial dentures, we have Virginia bridges. So there's a long list of resin bonded prostheses, direct, indirect. We have natural teeth, resin teeth we can use. Earlier natural teeth, now also we use sometimes natural teeth. Accessory retention can be with the help of acrylic. Composites, that is lingual attachment or proximal attachment with orthodontic pads. Cast framework like Rochette, mesh, retention bed. We have all ceramic as well as a resin bonded. Coming to the first one, that is Rochette bridge. As the definition goes of a Rochette bridge, it is a resin bonded prosthesis incorporating holes within the metal framework and alludes to the lingual aspect of the teeth adjacent to an edentulous space that replaces one or more teeth. Now that is all about Rochette bridge. How is Maryland bridge shown? See, this is how you attach to the enamel of the lingual surface, and this opposite way around actually. The teeth should have come this side. Then coming the Maryland bridge you prepare very less, and then there was a cast mesh. So you can see a mesh of cast mesh which was done on that, fixed partial denture was done. This cast mesh is fitted onto the enamel structure. Virginia bridges with the older time of bridges. Coming to the indication of these kind of bridges, the resin bonded indications are maxillary incisor replacements if they are in an open bite, or end-to-end or moderate overbite situation. Mandibular anteriors where there is no interference from the occlusion, no deep bite where incisal edge is wide and cervical edge is narrow. Abutment should normally be free of caries in large restorations. When adequate occlusal clearance of 0.5 mm can be achieved without exposing the dentine. When posterior occlusion is stable and the abutments protect the pontic during functional movements of the opposing teeth. As interim replacements where expensive, uncertain prognosis of both contraindicates other treatments. When periodontal support for the abutments is similar and abutment teeth are firm. Splinting of periodontally compromised teeth. Medical compromise in indigent and adolescent patients also we can use this. Whereas we are not supposed to use these kind of bridges, should not be used above average lateral forces are likely to be applied. Example in patient with parafunctional habits. Deep bite cases. Long span edentulous area replacing multiple missing teeth, not indicated. Short clinical crowns and narrow embrasure spaces present, not indicated again. Proposed abutment teeth must be stable and exhibit absolute minimal mobility. Extensively restored or damaged teeth can be not used as an abutment. The quality of enamel is again important here. Any defects such as hypoplasia, demineralization or congenital problems such as amelogenesis imperfecta or dentinogenesis imperfecta will adversely affect the resin bond strength. Aesthetic difficulties will also have a contraindication in these cases. So the main advantage remains is conservation of the teeth structure, preservation on conservative preparation of the tooth. Fabrication of a resin retained prosthesis, what are we are supposed to do? In the fabrication of resin retained FPDs, attaining to detail in all the phases is necessary to find out the success rate. That is, preparation of abutment teeth, resin to metal bonding, framework fabrication, we'll see one by one. Preparation of abutment teeth, in that the burr selection is very important. For gingival margins and tapered diamond burrs, chamfer round burrs can be used, circumferential preparation. For occlusal and incisal receipts, diamond, carbide, inverted cone burrs can be used. For additional retentive features such as slots, grooves and pinholes, tapered fissure carbide burrs can also be used. Framework design for the anterior teeth, how it should be? The framework design should be based on what kind of bridge we are using. We are using a Rochette kind of bridge. We can even use these kind of bridges in posteriors as well for replacing single teeth, where the heavy occlusal force is not there. Parafunctional forces are not there. In those cases, we can use this. Whereas other is that, like for example, we are replacing the lower anteriors. So what we will do on the palatal surface, we will give 2-3 holes on the incisors, the abutment teeth on both the sides. We will make the holes down like this 0.5 mm depth, and then we will etch it, and with the resin bond we will bond it out. So for that we need to know the bonding, the resin to metal bonding. That can be macromechanical, that can be mechanical, that can be micromechanical, or it can be microchemical as well. Now coming to macromechanical retention. Now example, Rochette bridge. The Rochette design has composite or metal retention by perforation in the metal framework backing. See for example the Rochette bridge. This is how it is. So now what are they indicated for? It is indicated for immediate kind of replacements. It is indicated for interim replacements, immediated for adolescent patients as part of a complex treatment plan during periodontal or endodontic treatment. For those patients who we do not know the prognosis, uncertain prognosis, or risk of trauma, like for example the patients who are into contact sports, for them it is indicated more. The mechanical retention is brought about by mesh retention, that is duralingual, or the salt crystals, the beads in the crystals. For example, the crystal bond is present in the mechanical kind of retention. Coming to micromechanical retention, what is used? Grit blasting is used. Like we have to sandblasting. Here with the 50 to 250 microns of aluminium oxide, we do a blasting so that the area will be edged out, and then we can adhere the particular tooth onto the tooth structure. Electrolyte etching, again with the help of electrolytes, that is cations and anions. When the electricity is passed through this particular tip, then that will create the etching onto the surface of the restoration, and we will be, that can be lab and chairside electrolytic etching units are present. We have micro etcher or sandblastings as well. These are sandblasting units by which we can be doing that. And now coming to the chemical etching. Now chemical etching, in what happens, some operators, they prefer to suitable chemical etching of electrolyte etching. Like for example in 1987, Ducodias said that a gel consisting of nitric and hydrochloric acid is applied to the internal surface of the metal framework for approximately 25 minutes. What was the advantage of this? That good retention was found. Thin framework was not perforated, and whole area became retentive. But there has to be some disadvantage. The etch is an alloy specific, usually nickel chromium alloy. Special apparatus is needed, of course. Retention may be unreliable. Difficult to evaluate the etching, how much etching has happened. And similarly, extra visit of the patient is required. Possible problems may appear with appearance of the patient. They have different, oxidizing pens are available. We have tin plating system. We have silicoator unit dispenser. This is called silicoator unit dispenser. Propane gas it liberates. Coming to microchemical retention, that is chemically active resins. Two effective materials are like Panavia EX Superbond or CNB Metabond. Panavia EX is a company of Japan which contains an active phosphate ester of bis-GMA in the monomer form. Whereas the super bond, which we are seeing, that's also of Japan basically. Only this Metabond, that is of USA. The CNB Metabond of USA, which contains 4-meta as the active chemical agent in the resin. So Panavia has got bis-GMA, whereas your Superbond and Metabond both have 4-meta as the chemical agent in the resin. Coming to what are the failures of resin bonded bridges can happen due to. It can happen due to inappropriate patient selection. Patient selection as in what? Poor alignment of the teeth, patient having parafunctional habits, insufficient vertical length of the abutment, inadequate virgin enamel for bonding, history of metal sensitivity with the patient, thin labiolingual abutment dimension, it can go up to the pulp and damage it. Incomplete tooth preparation, for example, what if we are not doing insufficient, we are doing insufficient proximal or lingual reduction, less than 180-degree wraparound we are not giving, lack of accommodation to protrusive movements in those cases, bonding of the RBP, bonding of the resin bonded prosthesis can fail due to contamination, it can fail due to prolonged mixing or inappropriate luting agent. If I use, that can also cause the failure of resin bonded prosthesis. But yes, when we have to talk about preservation of the tooth structure, conservation of the enamel, dentine, and doing conservative treatment, preventive prosthodontics, resin bonded bridges have come across in these today's time as a very important part of a treatment plan. Even when cases of implants, those cases of implants which are getting delayed, who cannot afford to have immediate loading, we can of course go for resin bonded bridges or fixed FRCs, that is fiber reinforced composite bridges, rather than going for a removable partial denture, which can be harmful to the health of the gingiva below that particular prosthesis.